saw that, I said, why would a doctor think about design? And so it's been a pleasure all these years following Joyce and what she does, because she's really been truly a public thought leader in the area of design. I see her truly as a Renaissance woman, as a NIH-funded researcher, and I think our only pediatrician speaker that we have today. But it's a pleasure to introduce Dr. Joyce Lee.
Thanks for having me. Really excited to be here. This is an amazing group of people, so I'm already feeling very inspired. Those are my disclosures. Just wanted to kind of communicate where I'm coming from in terms of I live inside an academic medical center. I'm a pediatrician and a diabetes specialist, right? In pediatrics, we don't get a lot of attention because our kids don't cost as much money as all the adults, right? So our budgets are kind of like a rounding error compared to sort of the money that's spent on the rest of health. I have traditional training in health services research, clinical research. I would say I'd characterize myself as a clinical translational researcher, but I think in the age of EHRs and population management and value-based care, like that work is even becoming more translational for me, and I'll talk a little bit about that. But I also have a big passion for participatory design and the maker movement. I love what the diabetes community and Dana are doing inside our system, because what they're doing is they're sort of taking the dysfunction and they're redesigning it. So I also do some work in sort of studying patient innovation and trying to bring the maker movement to healthcare. I'm right after Stacy. Lucky me, right? Right? So like this is the dream, right? This is the kid in the candy shop for someone who's really interested in health and design. But like, I just have to acknowledge that this is not my reality, right? This is our email. So what I think is so interesting about healthcare is they'll even take a really modern technology and they'll kind of retrofit it to the older one, right? So we actually have a email that parents can send their kids' blood sugars to that turns it into a fax that can be pulled off of in the office so that we can image it as a PDF into the media tab of Epic, right? And I think there's a lot about mindset in design, right? And this actually came from my unnamed health system, where there were sort of issues with pagers having interference. So they essentially sent out this system-wide email saying, make sure you keep your pagers at least a hand's width apart if you wear a number of them, to prevent like serious, major, fatal errors, right, in communication. So don't fix the problem, just make the user do a workaround and do a really big communication to sort of communicate that, right? Or like, don't change the default, like create actually more work for people across the health system if you're looking for administrative documents, right? Or actually give instructions. So we actually had a kind of a DME kind of provider inside our system, and they were basically like, we can't manage all this, so we're sort of shifting the diabetes supplies to other kind of DME manufacturers. So it's so interesting because the instructions that were sent to our patients, like our patient services coordinator basically said, do not follow those instructions. It will create the most work possible. So those are just some examples I think about, like healthcare not necessarily having a mindset that's oriented towards design and towards the user. So I think my approach has always been very bottom up, because I don't have millions of dollars in a system to sort of push forth, right? I call myself a maker. I think we're all makers. I've really sort of believed in the democratization of design and this idea that we all as healthcare stakeholders, whether we're students or physicians or residents or staff members or nurses, right, like we all sort of create the experience of healthcare and we all contribute to that, even in our daily work, even if we're not in an institute for design, right? And so this work has really come about through collaborations with obviously people from Mott Children's Hospital, but also School of Information, School of Art and Design at University of Michigan. So we, with our collaborative Health Design by Us, we've done a number of different kind of experiments and prototypes. We've had funding from the provost to try and do engaged learning for students in School of Information and School of Art and Design to sort of do more patient-centered design, work on projects that are kind of more directly related to healthcare. We've done a number of design thinking workshops for medical students, or sort of on the professional side, trying to bring their exposure of design to their world. And then we've also sort of had a focus on trying to work with patients as partners. So have done a number of different things, including kind of holding Make Health Fests, so sort of bringing the maker movement and healthcare together. in Ann Arbor, and doing all sorts of kind of participatory design workshops, sort of with this knowledge and understanding that patients are really the experts of their disease. Dana is the expert, right? My patients are the experts. I probably know very little about the lived experience of diabetes. So how do we kind of bring that collective intelligence out and sort of surface it to make it kind of a resource and knowledge that we can kind of leverage inside the healthcare delivery system. And then this is just a kind of an ongoing project. So and what we're even trying to do, and I think one of the creative things that I try to do, I think as someone who kind of intersects clinical and research, is that there's a lot of people who don't want to pay for design. So the question is, how do you integrate it into the research work that you do? So for example, we have a PCORI engagement grant that's trying to sort of bring the maker movement to teens with type 1 diabetes to get them to kind of engage with their data, but at the same time kind of train to be research advisors. So I think you have to sort of think creatively about how to bring design into a system that doesn't necessarily want to support it. So, we've had wonderful interactions with different students who've helped us make prototypes. Go to diabetimoji.com. It's kind of cool. This was an idea that came out of a workshop for a teen who needed to kind of communicate about diabetes with her mom, but needed a sort of a better way of doing it. So this is sort of the product that's evolved. And so we've really enjoyed some of the prototypes and sort of, I guess, the mini products that we've developed. But I think, some questions that I'm sort of facing now are, how do you get design sort of deeper into the healthcare delivery system? And I think, Matt, you showed those slides about business schools, right? I think in business, it's obvious, right? It's clear, right? And if you look at John Maida's design and tech report, right? Like, venture capital gets this, right? The startups get this, right? That design is really essential for ROI. And I mean, that typically is measured by, your billion-dollar valuation of your sort of Silicon Valley startup, right? But I think we have to think about bringing that to healthcare, right? What is the ROI in healthcare? And I do think, just sort of given all the converging trends of, CMS wanting to do more value-based care, people thinking more about population management, people thinking more about sort of taking risk at the system level, right? Slowly, these health systems are trying to move away from fee-for-service and trying to get to a more cohesive system where you do need design. So I think, one of the things that I've sort of tried to do inside a system that doesn't really have appreciation for it, and this is where I kind of get into this notion of the native language, right? Like, if I say design thinking, and innovation, to my people or to my crowd, those are foreign terms that don't make a lot of sense, and that would be a lot of hesitation to embrace, right? But, there's something called a learning health system, and I think this is the best description of it. Patients, caregivers, clinicians, and researchers working together to choose care based on best evidence. Together, they drive discovery as a natural outgrowth of patient care and ensure innovation, quality, safety, and value all in real time. This is a mandate from the Institute of Medicine, right? And that actually matters to the deans and the academics and sort of the people inside sort of the traditional mainstream centers that we work in, right? And so that's really, really important, is kind of bringing in the language and sort of the authority figures that sort of provide credence to this endeavor. And so I've been sort of doing, this is actually this is kind of the elements or components of what's needed inside a learning health system. You can download the report on the IOM website. I mean, I don't even know how many pages, right? So there's a lot to sort of dig into. But I think the point that I want to make is that it's referring to pieces of design, right? It's referring to engagement with patients and with the public, right? It's referring to sort of iterative processes, right, to design better systems. But I think a bigger piece of this, and this is sort of the journey that I've been taking as I've evolved as a designer, is that we need to measure ROI. We need to measure ROI in terms of value and in terms of outcomes. And then this is where, it becomes really important to think about methods that already exist inside the system, that are sort of well-regarded, that are accepted, that are to a great extent already disseminated inside our health systems, right, which includes quality improvement and leveraging that thing called EHR, right? So, quality improvement, I think I've had conversations with other individuals in the room today about, it being a science of improvement, right? And again, sort of having the credence and having a framework that a lot of health systems already use to think about improving care, right? And if you think about design and you think about quality improvement, they're kind of similar, right? And again, so this is my attempt to sort of think about how to take the things that I really care about and then push them into this larger system that's operating under a different culture and under a different language, right? But, you know, both of these approaches, they're both iterative, right? They're both about sort of trying something out, testing it, seeing if it works, and then making another prototype or making another step, right, to sort of modify or optimize, right? And so I think they kind of go parallel, but I think they are potentially a little bit different because design thinking perhaps is a little bit more about disruption. It's a little bit more about being more creative in terms of the solutions you might consider or develop, right? And it probably has lived traditionally more in the realm of product development, right? But at the same time, we really need quality improvement because even if we have this really great disruptive idea, if we are not measuring what the impact of that is inside the system, there will be no other Dell Med School, right? There will be no other Design Institute for Health, right? And so I think that these processes go hand in hand, and so part of my evolution is to say, okay, like, quality is really important, right? Like, I was trained traditionally as a health services researcher, so what we would do is we'd say, wow, the outcomes are really bad, and we'd publish the paper, and then we move on to the next grant, right? So, but I think, you know, now that we have that thing called health IT, like, there's a huge opportunity to take advantage of that and perhaps to measure, Stacy, right, all of the innovations you guys are making. You have an opportunity to look at those outcomes because presumably you're going to have a system that helps measure some of this inside your health system. So, you know, we've kind of locally in terms of our pediatric diabetes work, right? So I'm quality improvement director. You know, we've been thinking about trying to develop a clear measurable aim that we think is really important to the health system, right? So, you know, our hospital really responds to U.S. News and World Report, and glycemic control is something that's really important for our kids with type 1 diabetes, right? So really trying to map out what is our goal and what are the pieces that we need to achieve it. So this is a key driver diagram. This kind of comes from, you know, the IHI methodology, right? But really trying to think about what our main goal is and thinking about sort of the process measures that we need to achieve to reach that goal. And what's fascinating to me when we were doing this is, you know, we were trying to even capture metrics on how many times people are checking their blood sugar a day, or are they wearing a CGM, right? Or how many times are they giving insulin doses? Or are they downloading their data and actually reviewing it between visits? But frankly, we actually aren't capturing any of those metrics inside our system, even though we're seeing patients like every 3, every 4 months, and we're theoretically recording things inside the EHR. So in addition to sort of thinking about our plan, we've been assembling a team, and I think the key is that it's really interdisciplinary. And, you know, I've really enjoyed working with students, but I think, you know, part of this is the professionalization of design. So what we've tried to do is sort of garner all of our resources for QI, garner all resources for research, and then try and get all the players into the room and have them be staff people that can really contribute to this, right? So we have, you know, people with backgrounds in school, from the School of Public Health and behavior change and design. We have a visual designer. We certainly have a patient and family caregiver advocate, and I just want to mention that we actually do pay her for her time. We don't ask her to volunteer because we know that her time is valuable and needs to be valued. But we have sort of our kind of core team, and then we have sort of the larger clinical delivery program that we're working with to try and sort of make some of this change happen. And so we've begun, you know, the process of doing a number of interventions to support improvements in care, and part of this is just translating basic evidence-based care that is not kind of systematically being done inside the system. And we're doing this in part with a larger collaborative called T1D Exchange, which is kind of bringing together a lot of type 1 diabetes centers to do this work. But then we're also trying to think more about the patient engagement side of things. So diabetes, we know, is the disease that's absolutely not really impacted by the clinical delivery visit, but it's absolutely impacted by everything else that happens outside the clinic. So have begun sort of working on engagement with our individual clinical population, and then trying to do some experimentation with regard to engagement using some factorial designs and such, but under the realm or under the guise of quality improvement. So I think one of the most painful things that we have had to sort of face is sort of where the deficits are for our electronic health record. So my husband's Spanish, so I went to Spain, so we actually went to the Museum of Torture, and I took all these awesome photographs. So I thought I'd like bring them back to healthcare because I think it's a good metaphor, right? You know, I don't know. I'm curious, Stacey. I want to know, like, how many fax machines you guys are going to buy and, like, what electronic health record you're going to use. But I think most of us, right, have Epic, right? And it's, you know, it's an interesting technology, right? It's kind of more like Microsoft Word. It still looks like technology from the 80s or the 90s. And there's a lot of kind of deficits, I think, in the way that the system was built for us, right? So there's a lot of kind of choice in the build for this, and then what ends up happening is that health systems kind of just pick them up and kind of implement them, but I don't necessarily think that there's a ton of bandwidth or time spent in trying to think about the actual design of the system, even given that particular software platform and the implementation for the user, right? So, for example, we fall under ambulatory care, and there's 163 clinics that they serve. They have a really, really tiny team, so pretty much everyone has the same build, right? So that's really painful if, you know, because like what we need in diabetes is really different than what, you know, plastic surgery needs or some other kind of ambulatory clinic, right? So what we know is that there's a ton of unstructured data. Basically, we're typing in, and it is truly like Microsoft Word, right? We're typing this data in our notes, and we're losing all that data. We have a ton of missing patient-reported data because we were doing paper sheets that were, you know, being filled out in clinic and then being scanned into the system. We have a lot of underutilized data, so we're figuring out that there's all this sort of data about our patients that we didn't realize was actually being collected. For example, our social workers were collecting information about kind of social factors, but they were doing this for their billing purposes, and we didn't even realize that sort of rich data information was there. And then, in general, like the design of it has just been too many clicks, right? So they make us go to like 5 different places to get to where we need to be to make the right decisions for our patients. So I actually spent last fall, I think it's really funny, like I'm doctor's designer, and I'm like, I'm excited to be an Epic physician builder, right? So there's a program, right, where you can go and you can train, like Judy Faulkner loves when physicians kind of become quote-unquote builders, and you're not necessarily like programming. It's a kind of like a GUI that you're using to sort of design the tools that the individuals use for the EHR and also sort of the workflows, right? But you can go and you can get trained. And so I just wanted to share with you, like, that's how big their learning campus is. Like, it's like an incredible campus, but like there's just like busloads of people coming off to take courses in that learning center because the technology is literally so customizable. There's just too much choice, right? And I thought it was really funny that there was actually a little sign. There was like one room where they were doing usability testing, so I thought that was kind of interesting. But so I'm a Voyager now, right? You know, I think what we're trying to do, or what I have the capacity to do, is sort of take all these, you know, impediments and actually deal with them and fix them. And I think the problem is that when you talk to the IT people, they'll say, you can't do that, you can't do that, and you can't do that, right? And the thing is, you can, but no one wants to take the time to do that for you, you know? So, you know, I think I'm sort of designing at a meta level, right, like for our clinic, for the good of like the system that we want to build a learning health system, and for the happiness and joy of the physicians and CDEs, right, who are clicking too much, right? But there's opportunity here, right? And if we can learn from this, right, like I'm building a physician builder guide, like how do we translate this to at least, you know, 50% of the hospitals that are using this technology, right? And then finally, we are, you know, I think learning about things through our patient caregiver kind of partner that we otherwise wouldn't hear inside the system. So really just like this for the last 15 years has been our sort of like, when you get diagnosed, here's all these random pieces of paper, like let's photocopy them, stick them in a folder, and that's our new onset folder, right? So what we've tried to do is really kind of through the talents of our visual designer, Jake, really try and, you know, sort of make everything more of a cohesive experience, make this fit with the web. I mean, I can't tell you how many times someone would say, like, where's that handout? And they'd be like, I think it's in the shared drive, and no one has access to it anymore because we switched computer systems, and or it's literally in, like, the filing cabinet in clinic where no one has access to it, right? So trying to sort of make sure that our patient engagement materials all sort of line up, match up, fit with our kind of clinical guidelines, but also deliver more of an experience for the system, but really on a very, very low budget, right? So we use Wix.com for all this stuff in addition to Jake's Talents, right? And then I think that's kind of an interesting story. So, you know, we have kids who come in for clinic and then they're there for a really long time and they go low, right? So we know that there's like juice, there's crackers that the MAs can get in order to give them kind of a rescue for their low. But it's interesting. So this mom was telling us about how people get really embarrassed about coming to clinic and they forgot their supplies or they didn't bring enough stuff to treat a low, right? So they're embarrassed about being low, but they don't know, you know, we know that it's somewhere there in the hallway, right? Accessible by someone, but the families don't want to ask, right? So this is just like a really simple fix, right? Just putting that sign up, that's like a cabinet that's inside the rooms, and then you just open it, and then inside there's that whole sort of batch of supplies. But so I think it sort of speaks again to sort of, like, I never realized that this was an issue. I didn't know it was a problem, right? But like there are sort of small fixes that you can use to try and improve some of the patient experience. So actually just posted this today. I get, like you guys, I get random emails from like med students who are like, I really want to do design. Can we talk? Right? So I did a post, and it was really interesting. So this is a student from Stanford, and she asked, you know, I gave up medicine for design, and I want to know if I even needed to make that choice. Right? So I replied back to her. And I sort of conceded the fact that, like, no one in my institution even knows what design is, right? So, but I think that's an advantage, right? Because the issue is that if they don't know what a designer is, they're never going to hire one, right? So I need to be the insider. Like, I need to be the person that's just like them, who understands their burden and their need, right? And says, no, this is really important. This could be completely transformative, right? And I do love the fact that, you know, there's so much dysfunction inside the system that you have just continuous exposure to it every single day, right? So you don't even need to like do it outside of what your work is. Like in the midst of delivering the care, you can absolutely kind of see it and witness it, right? But I think, you know, credibility is a really big piece of this, right? It's easy for someone to come from the outside and say, I'm going to fix all your problems, right? But I think, you know, recalcitrant medical professionals, we got a lot of those, right? You got to be in the system to know how the system works, right? To be able to sort of kind of gain the trust and like the optimism among your colleagues to really be able to kind of create change inside the system. And I sometimes think, like, unless you're building a new system from scratch, this is the way that we have an opportunity to kind of make culture change inside our healthcare delivery system. So I'll just end by saying that design is a mindset. Don't accept the status quo. I design at multiple levels, whether in a clinical encounter, whether I do clinical or research, right, or whether I do EHR redesign for our system. And I can't stress enough the importance of designing with patients and caregivers and doing co-design. So thank you.
Great. That was a wonderful contrast between, I guess what?
My sad life.
Well, between the way you, I don't want to say that. No, the way you are leveraging these tools to get into a system that isn't ready for change, contrasting that with Stacy's situation where he's got a flat thing. So.
Stacy, you need some help? No, just kidding.
Questions?
Hi, I'm a biomedical engineer, and I've always debated going to med school or not. And you said you gotta be in the system to know the system. So I'm thinking about health systems. Stacey's program also looks really interesting. But if I really, really want to provoke change, would you recommend going to med school?
So I think part of it is like, what do you want to do with your day-to-day, right? Like if you want to design the next new medical device that could transform the lives of millions of people, like probably you need to do that inside a company because that's the place where you can have your impact, right? But if you're trying to sort of do more change inside a system, then I think it's extremely helpful to be like one of the natives because it's really hard to get in if you're not, right? And it's really hard to understand the mindset and the culture if you if you're from the outside. So I like advocate it, but part of it is probably also my rationalization about like where I sit and how I can bring design to the work that I do in the system that I live in and the context that I exist in.
Thank you.
Actually, just wanted to add on to your comment, just to kind of in the spirit of the discussion. I also wanted to say that one thing I've noticed in our program is that I do feel that I don't take credit for the students that come through. I think I'm actually more, our programs like these are, there's a new space for these students who already have an idea that their medical career is not going to necessarily only be clinical. And that when I went to med school, I wasn't allowed to say that out loud, even though I already thought I was going to do public health. So I would say you also may be going to medical school may mean a different thing in the future, which is interesting. And I think it's also part of what maybe needs to be designed. So, but I agree with Joyce. I'll add to that ultimately people forget, like, we build our CVs in this kind of abstract way, but ultimately, what do you want to do Monday through Friday? What kind of stuff do you like to do? And then go from there.
Medicine really forces you into those channels, doesn't it? It's remarkable how I went through residency and postgraduate training, and you get forced into one way of doing things.
So thank you very much. Could you briefly tell us about your journey in partnering with your organization to accept this huge change revolution that you're proposing?
Well, so it's interesting. So like I think I have like notoriety on campus for being someone who embraces health design, but I don't necessarily think that people are coming to me saying like, I want to do this, right? So I think sort of I'm trying to operate inside the system. I'm trying to operate with language and culture and norms that are kind of accepted, but trying to weave it inside. So I mean, I think social media definitely helps. I have to say that. So, like, Michigan is the perfect example of an institution that has an incredible resource of really talented people across all the schools, but like no one talks to each other, not even inside the medical school, right? So, I think those silos need to be broken. But I also think that, you know, we're trying to sort of create change within our sort of smaller system. We're really a microsystem because we're pediatric and we're diabetes. And I think we potentially could have like an opportunity to sort of do something bigger for like, say, for example, the adult diabetes population. But I think just right now in our organization and in our kind of system, there's this question of like what individual kind of motivated people can push versus like what comes down from what gets funded and what gets supported, right? So, you know, our system is kind of in a rebuild now. There's been a change of leadership. There's now, you know, a huge group of kind of individuals who do quality analytics. I think, you know, improvement is getting more into the parlance, but I wouldn't even say that necessarily like that, which is, you know, kind of bread and butter for a lot of health systems. That's kind of new and burgeoning in terms of how it's going to be organized and executed in our system. So I think, you know, that alone is change, let alone like saying, oh, by the way, have you heard about this thing called design and innovation, right? So I think, you know, I try to bring my voice to it. I try to sort of leverage sort of energy and talented individuals inside my institution. But I think, you know, ultimately, this has to be accepted from the C-suite, and it needs to be brought down, because if it's not, there's not the resources, there's not the bandwidth, and there's not the vision for really trying to say that this is something that needs to be supported.
Okay, thank you. That was wonderful.